I have to say, I loved reading your book. I really, truly
Yeah.
did.
After I had it published and after I sent out, after I sold the first couple of hundred copies, I read it again. And I have to tell you, I actually liked myself a little better after reading it.
That but that's what it's all about. You
Yep.
gave back, and then you realize you actually gave back to yourself.
It's funny that today I posted a video because someone asked me the inspiration behind writing the book in the first place, and I hadn't actually talked about it. I've talked about it with people offline, but I hadn't talked about it with with the community,
Yep.
and so it was a little bit cathartic to actually get that out. You know, so what did you think? I'm gonna start out asking you a question. What did you think about what was your favorite part?
I think I'm going to show you. Look at how much I have highlighted.
I should have grabbed.
The back of the book, the nitty gritty, was my favorite part. My daughter was like, "Mom, why are you coloring all over the book?" And I told her,
You told me that damages them.
I told her, I said, she's like, "Mommy, you're ruining it." And I said, "No, because you know what? This is all such valuable information that I needed to highlight it in certain parts."
I don't know if I really had a favorite part. I think my favorite thing about the book in general was just the fact that it makes things so much more accessible for people.
That's generally, I've already experienced lots of folks saying they took it into their appointments and it didn't change the appointment, and that's true. And that's part of the purpose of the book is if you take it into the appointment and it changes nothing, then you're at the wrong place.
Right.
Right. And then also in the book, I agreed with you on the part where you said you're in that 15-minute visit. You might need to give that doctor a second and a third chance sometimes because they don't get a chance to get that good impression right away. So sometimes you got to stick it out.
Sometimes you do, but they tell you so much, though. I think that when they come in, like for example, I had to answer another question today where the person went to their new pain management person, and before they ever got 5 minutes into the conversation, they were talking about we're going to start weaning you down off your medicine. And that's why I wrote the chapter in the book that says the first visit tells you everything you need to know. Your relationship is not going to improve from that point. If you
Right.
haven't even taken a chance to get to know me as a person, and you are already deciding the treatment plan, that's not going to be a therapeutic relationship. And that's the number one reason why I wrote the book is that things like that ahead of time. So maybe you're not wasting your energy and your heart, really. You're not wasting all those emotions on somebody who's not going to reciprocate your love. And the thing about it is, and it's a foreign concept now, but I hope at some point it won't be. But I believe that your relationship with your provider should be a loving relationship, not just a competent relationship. It should be, your PCP especially should be someone who genuinely and affectionately cares for you. Even if it feels too cringy to say "I love you," which my patients, they just have to get over the cringe because I say it all the daggum time.
Right.
Even if it's too cringy to actually say it, it should be obvious.
For
We
sure.
a lot of us grew up with parents that weren't really good at saying it, but we knew we were loved. And I'm at least, I think that healthcare needs to move to the point to where it's at least that good.
What I experience a lot is there's no continuity of care. You don't have that. There's so many of these providers are over flooded with patients, and they don't have that minute to get to know you.
But that's what I like about the book. The book allows you to help them get to know you in a more efficient manner, since basically it allows you to tee up your life story in a way that even they have no excuse. They have no excuse if they can't sit still for 3 minutes. They're not worth your time either.
Right?
I consider the 3 minute life story the most important chapter in the book. Because if you can't get somebody to sit and listen to you for 3 freaking minutes, Again, you're not. It's not going to get better from there.
Do you feel like if you can't find that, or you have it, or like let's say you have it, like let's say you were someone's doctor and then you're deciding, okay, I'm going to retire or something. Whenever you go into other doctors and you're trying to find like that person again, do you feel like the patient will go in with like blinders on and won't accept somebody just because they had what they needed and it disappeared?
It's a thing. I mean, once you've had really loving care, you don't. I will say this: it makes it harder for you to find that next provider. It really does. But at the same time, it's a whole lot like someone sometimes what you have to do in a pain plan. Just because something is only going to give you a greater quality of life for the next 3 to 5 years doesn't mean you're going to sacrifice those 3 to 5 years because of what might happen after that. You know, we spend too much time worrying about whether or not we're going to be able to be happy in the future that we sacrifice the now. And
And
but
I,
to your point, one of the things the book covers about that is, sometimes you're stuck in a relationship that isn't therapeutic, but
Mhm.
you know that it's only for a season. Okay, you know that it's only for a season because you're not going to quit looking. You may keep going to that provider who's not therapeutic, because why would you cut off your nose to spite your face? But the whole time that you're going to that provider who is not the one for you, you know that you're there by choice, not because you are a prisoner of that relationship, and you keep looking for the next one.
What do you think, and I'm curious to get your opinion on this, what do you think is the most valuable part of the book in general?
The part that reminds you that you're not a bother, that you are not all the things that you say to yourself in the mirror. Honestly, the biggest barrier to getting the care that you need and deserve is your own feelings about yourself. I just and this concept that you have, somehow, because of your diseases or because of your diagnoses, that you have somehow become, taken yourself out of the pool of the worthy, is just some bullshit. And I spend a good amount of time, really fighting that internal voice, and because it needs to be squashed. You're wonderful. You may not be easy to deal with sometimes. Listen, I mean, there's a difference between worthy and wonderful and easy to get along with. Okay, but it doesn't matter if you are not easy to get along with. You should continue to try to find that provider that's going to make you feel like you're an addition to their life rather than an inconvenience.
Do you think pain patients in general, do you think this is the most common problem for them? Because I feel like this also pertains to like therapists and all types of different medical professions.
It is absolutely not just, and I think to a certain degree that's why I ordered the book. That's why the book is ordered in the way that it is. That I talked to all patients first, and then I dealt with controlled meds, at the end of it.
Right.
Because there are certain things that just transcend, and even people who don't have chronic pain will get a lot out of the second half of the book, because there are things that transcend. There are because, let's say we're not talking about opioids. Let's say that we're not talking about benzodiazepines. Let's say we're talking about blood pressure medicine or diabetes medicine. You know, be, it still requires the same level of one-on-one engagement in order to activate a plan that is going to improve the quality of your health. As a matter of fact, it's not that pain management things work with other patients. It's that the same stuff works with all. It's just the reason why there's half that's for pain patients is because they're the ones that are being systematically disregarded and disenfranchised, And so everyone can benefit from the second half of the book, but probably the people that need to hear it are the ones that don't have hope, and those are the chronic pain patients.
so I wanted to ask a question about like the urinalysis, the drug screens that you do for people that you prescribe certain meds to. What if they were doing one of those where they're trying to save some meds for a rainy day and they got called in like 3 days later for a urine screen? That would show, right?
It still shows, yes, it still shows. And
So
remember,
you so
I've
you
never
should be
advocated.
honest, right?
That's true. You should be, but remember, I've never advocated abstinence as a way of building medication security. I've recommended underdosing, but never abstinence, because
Right.
abstinence causes its own sudden abstinence causes way
Withdrawal.
too many problems. But and so the thing about it is they are a twofold study. One, you want everything that you're prescribing to be in there, and two, you want the things that you're not prescribing to not be in there. And that's why I there's a lot of things that I do that might seem cockamamie in some places. One of the things I do for my patients who cannot pee on demand, I'll let them bring in a sample. And or if someone gives me a sample and it doesn't make that temperature thing goes up, I'll run it. I'll run it anyway. And some people would ask me, well, why would you run a test like that? Because it's very hard to give correct dishonest samples. It is very hard to give a correct dishonest sample
Right.
for
I
everything to
learned
be in there
that.
that's supposed to be in there, and for the things that are not supposed to be there to be absent. A lot of times when people, it's funny because when people buy pee, and by the way, yes, that's a thing. When people buy pee, they usually don't get what they pay for. I'll just say it like that. It's maybe it gets them by one test, maybe two tests, but eventually when they get too comfortable, they are the process is the process, and I don't worry about people who are dishonest with the process, because the process is based on honesty, and when you are being dishonest in a system that is based on honesty, you will be found out. It just will.
Yeah. How obvious is it whenever you are doing like you're trying to save a little bit, so you're taking maybe half your dose, and then you do that for 3, 4, 5 days maybe, and you have to go in for a drug test? How obvious is it that your levels are so
We're
much
talking
lower?
about dose dependent levels. Now we're
Right.
Right.
talking about dose dependent levels. Basically, can I tell that you're taking half of your medication instead of all of your medication? No, the test I don't consider the test reliable in that way.
Okay.
However, it sometimes generates conversations. Like I don't think that is I don't think that you can tell that you can say, well, you're obviously consuming 30 milligrams of Percocet instead of 60 every day on a urine drug screen. I think that anybody that thinks they can doesn't understand the test. Go ahead, Marie.
So have you ever done like peak and trough tests to see like when?
With you, if you're at that point, there's not enough trust in the relationship to be in the relationship. You see, that at some
Right.
point, you have to have enough trust in the relationship to just be in the relationship. And if the whole relationship is detective work, you don't need to be writing medicines to that person. That person needs to be on medication assisted treatment. That person is a substance use disorder patient, and you can love them just the same, but they get different therapy.
We were talking about too the use of like marijuana whenever you're taking in your patients and everything. Um, for those people that are like chronic marijuana users, do they get heavily penalized? Because
At my clinic, they don't get penalized at all. Yeah, matter of fact, I consider the use of THC something that allows me to keep the rest of their pill burden low. I am
Right.
actually
Therapeutic.
an advocate. I'm an advocate of THC as it is useful in chronic pain and emotional illness. But it is an advocate. It is an adjunct. So the one thing I do tell my patients is that, yeah, you can have THC in your urine, but if you're always blowing off the top of the charts, I'm probably going to
yes,
talk to you about staying stoned all the time.
I feel like if I got my levels tested right now, they're gonna be at the top of the charts. But I feel like I can maintain that way. Like it helps it helps me to not take medication.
That's a different clinical goal, what you're talking about right there. What you're talking about there is that THC is your treatment, not an
Right.
adjunct. You see what I'm
Right.
saying? When THC is your treatment, not your adjunct, your levels are always going to be higher. Okay?
Okay.
Um, But when THC is an adjunct, and it's a genuine adjunct, you should not be blowing off the top of the charts, because at some point we all, the problem with this is that all these things are hot button topics. We just can't just have plain conversations. But when I say that when you combine opioids, benzodiazepines, and THC, at some point you're not mentally, where you need to be in order to manage all of your life and things like that. There comes a point when clinically it becomes a concern. It doesn't mean that you can't be on all three of those people. I have many patients that are on all three, but at some point, if we're just pinging the tops of everything, a greater conversation has to be had about whether this plan is actually doing what we want it to do. And again, is
Right.
it
Like,
about
is
dismissing them? It's not about dismissing them. It's about trying to strike a balance between clinical concern and quality of life.
now, what if somebody has a liver issue that comes up with like a liver issue and has pain? What do you do?
You give them as strong a dose as you can to manage that doesn't cause their liver to worsen. You have to realize that you're riding a bicycle with flat tires. You're only going to be able to go so fast.
Right.
Or your pain medicine doses are only going to be able to be so high. And liver disease is actually one of the easier ones because you can use higher doses usually in liver disease. But lung disease, heart disease, those are the ones that really end up causing me to have to underdose somebody if there is such a situation. It's the ones that I have to choose between pain or breathing. And unfortunately, when it comes to it, I choose breathing any day that ends in Y. Because
Right.
as much as I want you to have no pain, it's not my job to accelerate your trip to heaven.
Do you mind talking a little bit about what these medications can do to your liver?
Most of the time, most of these medications can be used fairly straightforward in liver patients, even benzos, even opioids. Um, it's not often that dose limiting, the liver disease itself. Again, what do you have to do though? You have to watch because it's not if they start going loopy in the brain, it's not the medicine, it's their ammonia. So you have to watch all the other clinical signs. If anytime a patient gets confused, something's wrong. It's just not always the freaking medicine. That's the problem with the problem when I run into like ERs and especially ERs. If my patient goes to the ER and the number of times that they come out of the ER and they had a COPD exacerbation with pneumonia. And they're like, the problem is their medicine is too high. No, the problem is they had a condition that almost killed them. And that's why
Right.
they were acting, you know what I'm saying? The most important thing to understand when someone's on chronic opioids and chronic benzodiazepines is that everything matters, not the fact that they're on opioids and benzodiazepines. The rest of it matters too. And matter of fact, in most instances, it matters just a little bit more than the controlled meds.
Sure.
Because
Okay.
I don't sit there, it is not a, if I have a patient that comes into my office just a little bit too close to bed, you know what I'm saying, all the time, you got to understand that's not their plan of care. We change something at that point. If they really are clinically inappropriate at a clinically inappropriate level of somnolence, those doses are too high and something has to change.
Okay.
But again, if their heart failure is controlled, if their COPD is where it's supposed to be, if their sugar's not 600, if they don't have a UTI, if, but even in a pain management office, we start with the opioids. Why do we start with the opioids? It's the quickest thing to change. You can't just snap your fingers and a liver fix itself.
I've talked to a lot of people that have had liver issues and it stopped them from getting on mat and all types of stuff. So I was just curious.
Now I understand there's one mat that it does stop them from, and I get that. But you see why I understand now where what you were asking, and this is why we never got to it. I don't prescribe methadone.
Right, right.
Methadone would be the one issue that we would get into where the metabolism is already a buttload of time, and now if you have a liver slowing that down, yeah, that gets into a lot of accidental overdose type scenarios. But I don't prescribe methadone, and I probably, it would be something where I would have to solo specialize in pain. I would have to get out of primary care for me to feel. I don't think primary care, as a rule, should be in the business of prescribing methadone. I don't think we understand. I don't think primary care understands the pharmacology enough. I don't think it should have as much of a bearing on Suboxone because of the way that it's only a partial mu agonist, antagonist or agonist, excuse me.
And I've heard doctors talk about that where they actual like mat doctors that they basically say that it can be very hard on your liver, so you have to be careful, all types of stuff, and they end up putting them on like 2 milligrams, 4 milligrams, something, and that's not enough for the patient, and they refuse to raise them, and it's always surprising.
Now, I have a problem with that. First of all, if you're going to be that uncomfortable, don't start. Let me just say that. I mean, if you're going to be, if it's that heebie-jeebie, then just don't start. There's one of the things I see in a lot of hurt feelings in the pain community is where someone to be honest, nobody that prescribes a controlled med is trying to trying to be unhelpful.
Right.
But if your level of comfort is only going to say, I can only give you 25 hydrocodone 5 milligrams a month, and that's all you're ever going to get, you probably don't need to be in the business of routinely prescribing opioids, is all I'm saying. Let's go to pain management, though. If your worry about this patient is, if I put you on higher than 4 milligrams of methadone, they are not a methadone candidate. If you cannot adjust their dosing because of the legitimate clinical concern, it just means that patient shouldn't be on. That patient should be a Suboxone, or that patient should, honestly, if you could manage them, should be on traditionals. Go to hydromorphone. But again, we're not talking about specifics here. Since we're in the South, I can say specifics. But we are. There's just some places you just don't start. You don't start down a train. You don't start a train that you're worried you won't be able to make it to the station.
Can we talk about trauma causes pain and pain causes trauma?
The whole concept that I can't treat your chronic pain because your chronic pain is born from your trauma, except that if you don't treat that chronic pain, you're going to cause trauma, and that's going to cause more pain. Let's take the easy one, fibromyalgia. Fibromyalgia is a stress-induced illness, okay? It is where you have been under trauma for so long that your own nervous system is now screwed up and haywired, okay? Everything about fibromyalgia, all the pain is absolutely real, but it is, I say it to my fibromyalgia patient, whereas a lot of pain is outside coming in, fibromyalgia patient is truly born from the inside and it's coming out.
Yep.
And, the whole concept that you can't manage that pain with opioids is ridiculous, especially when they keep trying to put them on Suboxone.
Right.
That chapter was born of the fact that one of the things I get the most indignant about is someone who grew up with child molestation, and they were literally broken in ways that many of us will never ever understand. And they go, well, it's because of your molestation that you have pain now. I say, so what? So what?
Treat the pain.
Whatever the cause of the pain is, you're right. We're not treating your molestation. We're treating your pain. And if you can treat their pain, guess what? They can start working on the molestation. They can actually start working on healing from that. And but what is healing? Listen, I've got 7, 8, 9 places on my body that are completely healed that you can tell where I got hurt. Why? Because it left a scar. Not every healing means that you return to where you were. It just means that you're no longer in the thick of what that was, and it no longer runs your life.
Do you think that it's more beneficial for if that is an issue, you, I guess, get your issues taken care of first? Does that make sense?
Then you're saying to them, when you recover, we'll treat your pain. No, that's what I'm saying. It's and.
There should be an order.
Well, yeah, one of my favorite chapters in the book is where I rant about the word and. You're treating and you do it's get your mental health taken care of. It is treat it with opioids, use non-steroidals, do cupping, massage therapy, do red light therapy, do it all. It's and. What you're trying to do is you're coming up with the plan where it inserts life in the middle of misery. Okay? When
Right.
you're coming up with a plan that inserts life in the middle of misery, you don't talk about what you're not going to do.
Right.
You don't talk about what you're not going to do. You got to talk about what you're going to do. This whole concept of, we'll treat what's left over after you heal. Well, how are you going to heal? As a matter of fact, that was one of the videos yesterday. One of the videos yesterday talked about how do I ask for stronger meds after surgery, and my answer was this: you ask them, basically, what is your plan for my acute pain? If they say that you're just going to use your same medicines that you always use, you're going to let them know that they barely work most days. They don't relieve my pain; they give me function. And what I need to know is I need to heal from this surgery. I have to have the tools to heal from this surgery. So what am I going to have for that? This is different.
I think
Even in
when you
pain
talk,
management, I don't tell people. Go ahead.
I think when you talk to your doctor, you as a patient, what I got out of the book is you have to humanize yourself to the doctor. Like you have to
help them
let
see
them
you.
know, right? As a whole, as a family, like I got these kids, they stress me out.
Right. This is where the accountability partner comes in play. There are times you should not be in that doctor's office. That's chapter 3, y'all. There are times you should
Alone.
not be in the doctor's office by yourself. Now, I
Right.
don't care how good of an advocate you are. Even I carry my wife with me to some appointments. There are some appointments that are just that necessary. And if you think I can't advocate for myself, I absolutely have all the skills. But even me is going to have that second voice. You know what? Quite frankly, sometimes that second voice has got to, they got to go, now, honey. Because sometimes I need to be toned down just a little bit. There's a
Right.
reason. There's a reason why I say that everybody needs to have a second person in the room for some appointments.
And you talk about not like going into the doctor and requesting a specific medication. Is there a workaround for like if you do have a person with you?
You absolutely can tell a doctor what has worked before. You
Right,
should,
right.
as a matter of fact. I'll even go one step further than that. If you had a successful plan before, especially if the reason why you're going to see them now is because they force tapered you off of that plan that was working, it's perfectly fine to tell them what has worked before in the context of simply making a statement. It's more like it should be a question answered rather than the goal of your visit. Don't make it the goal of your visit, okay?
Right.
Because when you are being the most effective at advocating for yourself, what you're doing is allowing the provider to come to the conclusions you hope they come to. And you're also being prepared for the fact that you don't see you 100% clearly. You may know yourself best. You absolutely know yourself better than anybody does, but that doesn't mean you see all things related to you clearly. Okay? And so the goal isn't to get a certain prescription, it's to be heard. And as long as that whole conversation focuses on being heard, then even if you don't get what you want at that particular appointment, the building of this relationship says basically I'm playing the long game. Okay? And if you're going to treat me like a human being, you're going to see me for who I am. You're going to explain to me why I'm not comfortable doing that yet. And there is a genuine hope. Now, if your first visit is, I'm sorry, but I'm going to do Percocet 10 3 times a day, and that's the plan.
Right.
That's a whole nother chapter. That's a whole
Right.
nother chapter. That said, the first visit tells you everything you need to know.
Is there a system that has like certain people red flagged?
I've been dealing with that a lot. I've been dealing with that with most corporate electronic health records have some sort of red flag system. They do. They absolutely do. Whether it be drug seeker, whatever ugly words we want to use today. And by the way, before I say any more of them, I'm going to say I'm just talking about ugly labels. Whether it be drug seeker or whether it be substance use disorder patient who does not have substance use disorder, and all of those things. Most corporate medicines have some flag like that. Now, the question I keep getting is, what do I do about those labels? And the answer, my best answer is nothing. My best answer is you keep working with at the provider level and waiting to find the one that sees you, because even some corporate medicine docs will look at that chart, see the flag, look past the flag at the person sitting in the chair, and go, oh, that's the person I need to worry about, not this label.
The whole concept is humanization. Like, you're humanizing that person.
And that's the point of the book is to find, because the system, you got to understand, the system will never be human. Okay, so the system is going to have, I told you, this goes back to that list of diagnoses, and when I told you that I just wanted to add number 15 cooties to see how long it got perpetrated in the chart. Okay, the system will never see you as a human being, but you can, even in corporate medicine, find doctors who will see everything that's in your chart, everything that's been written about you, ugly or otherwise, and actually go, I'm going to take care of the person I see rather than what I'm reading. And I'm going to give them a chance to prove to me whether they are what's in the record, or whether they're what's sitting in front of me. And I'm going to tell you this: anytime I've given a patient the opportunity to show me what they are as a person versus what they are in their record, the vast majority, 90% of them, have always shown me that what I see in person is the true story.
What I was thinking, if you have that extra person with you whenever you go to these appointments and everything too, do you feel like that can help reinforce some of these things where you have all those red flags on the chart, but that person with you can kind of say, yeah, this stuff worked for him. Yeah, you have like a backup in everything that's going on, and it's not just your word.
Or another thing, you have backup, especially if that person has been a stable accountability partner in your time. They can actually say, I was there the day that got put in the chart. And let me tell you what really happened. And there isn't, I will say this: most people, when are in healthcare because they want to help people, and if they're the kind of person that will at least sit still for your 3-minute story, they're going to be able to sit still for your 2-minute your side of the story. The number one thing you have to avoid in situations like that, which is why they're in the chair next to you, is the trauma vomit. So where basically you completely jump off of the point onto every way that you've been hurt, and you're not actually, basically when you trauma vomit, it is understandable. It just usually doesn't allow the conversation to move to a problem solving mode, is what I'm trying to say.
Yep. Yeah, and that was kind of what I was wondering about. Just there are so many pros and cons to having that extra person. I guess just as much as you want to find the right doctor, you want to make sure you take the right person with you too.
Not everybody should be sitting in that chair. Let me tell you what. I'll say that there are certain people, like my daughter, my youngest child, is on the trans spectrum. And I think that there are certain situations where I would not be her best accountability partner. I would not see things as we would not be in agreement enough. I'm a pretty darn, I'm loving her where she is and everything that it is, but I'm still dad. And there are moments when there are situations when I would not be the best accountability partner. Like if she was to go talk about top surgery, I'm not the person that you want to have in the room next with her. And and we know this. We've had this conversation, and she's thinking about it, and that's fine. And I love her, and she can do it. I raised her to live her own life, but in that moment, I'm not the right guy, and so she needs somebody else. So that person that you choose. There are definite. The book gives you definite things to think about.
We kind of skipped over it earlier, but there was one thing that we were kind of talking about before this. You mentioned you accept the whole smoking and all that is fine. What about psychedelics to a certain extent?
It's not that I don't think I have a clinical opinion one way or another, because nothing gets tested for on those. There's not usually a respiratory depression component to that. And so, and now we're even getting into things like esketamine, which, is also known to cause hallucinations. So I'm probably, I'm probably right now woefully ignorant as far as how to adequately incorporate it into my plans of care. But I would say this: I know my patients do stuff, and I can't imagine that they don't do psychedelics. And so far, I haven't seen any real clinical trouble. So for right now, it hasn't become a detractor in their plan of care.
So I was going to ask about gabapentin because you talked about that in the book a lot.
Okay, so what is gabapentin? It's an adjunct. It is only ever meant to be an adjunct, but it really is just that. And when and when it's used appropriately, it makes a huge difference, especially in neuropathic type conditions. Now, am I a bigger fan of Lyrica? Probably. Okay, but do I use gabapentin every day that ends in Y? Absolutely. But I don't use it. The difference between a gabapentin in my plan of care and a gabapentin in other people's plan of care is as follows. I look at them and I say, this is what I hope the gabapentin will do. And if it doesn't do that, then we'll stop it. Okay, if it doesn't add this to the plan of care, like for example, the place I always start gabapentin is at bedtime. I said, I'm looking for your mornings to be a little bit better. If your mornings are not better, then we stop the medicine. So
Right.
it's very, whenever I start something like that's an adjunct, whether it's a medicine for depression as an adjunct for pain or anxiety or a neuropathic or something like that, there is always a I mean, like, so that we each can equally describe it, goal. So because they're the ones that are going to tell me if it did it, and they're the ones that are going to be authority on whether or not it's working. So they have a very specific statement to come back to me, yes or no. And that's how I see gabapentin when it's used correctly, the best way that it's used. You'll hear me talk a lot about the needle moving because in most things about you're trying to move in a direction toward life. So if I don't see the needle moving by the time I get to 1,200 milligrams total per day, we abandon the therapy. I don't have anybody on 3,600 milligrams per day that didn't ask to be on that much.
Gabs are getting thrown out there so much still. I feel like it was I don't know, like 8, 9 months ago, it was a big thing. Everybody was really noticing how much they were getting prescribed. And then now I haven't seen much on it lately. So I don't know if something got done about that or what.
Probably just this season. Trust me when I tell you that the chronic pain, pain management services, traditional pain management services, still love gabapentin as much as they ever did. And again, the issue is not how they feel about it. The issue is how it's presented to the patient. At the end of the day, that's everything the book is about. That's everything the book is about. It's how the decisions are made. And do you get a say? And by gosh, doggone it, if you're my patient, you get a say. You don't get the final say. I am the prescriber. But bless God, before I can have my final say, we're going to have a real talk.
What has been going on to, I don't know, kind of combat all of the stuff that the DEA is knocking out for the pain patients?
I'm going to be honest with you. I feel like right now we're in kind of a sad time, and I'm just trying to hang on and, be confident in the little island that I'm trying to create. And honestly, I'm hoping that the more everybody is talking on the same playbook, my biggest goal for this book, if this book was to actually perform a miracle, it would be that the DEA would start seeing patients again, and meaning that they would start seeing quit cracking down on a drug and start helping a patient. They're shutting down docs and I'm not saying, look, we got bad apples too, okay, but they're shutting down a lot of docs that aren't bad apples. They're shutting them down in dishonest ways. They're shutting them down because it's easier to shut down than worry about whether you're going to go to jail. So it's kind of like a bloodless war. You understand what I'm saying? The murder is the loss of the provider.
Yep.
And I think that the problem is that no party, both the Republicans and the Democrats, have been equally snowed on this issue. So there's no party that defends the pain patient. There's not, and so all I can do is change one conversation at a time. That's what the book is about, is just to keep changing one conversation at a time.
Have you ever thought about like trying to teach? Because I think you would be amazing at teaching.
I do think about that, but here, let me give you a couple of reasons why I don't. Actually, let me give you about 500 or 600 reasons why I don't.
Yeah.
Who's going to
Okay.
take my folks? Who's going to take my folks? I would love, though, to guest lecture. I am open, and I have said it many times, to any med school or any nurse practitioner program. I would love to come lecture on patient provider relationships and help you understand how to see a patient. And I would love to be a guest lecturer that just kind of squeeze these people in without sacrificing my clinical practice, because I don't know that there's not somebody that's just waiting in the wings to pick up where I left. And
Right.
Right.
because there's not, I have a hard time just saying, well, I need to do this because I think, I'll save more lives as a teacher. I can't we're back to the whole, I can't sacrifice the now for the possible. I feel like if I get this out far enough, that if enough people get the word, then it's going to generate. I'm actually looking forward to the pushback, because it's the pushback that's going to actually start the conversation. You understand what I'm saying? When we have, it's one thing, oh, it's great, oh, it's great, oh, it's great. When somebody finally goes, baha, baha, then all of a sudden we can start having a talk.
So one of the things that I feel like happens a lot nowadays is you don't get that conversation whenever you do get pushback. You get the pushback, you give a rebuttal, and then it's still more pushback, just repeating the same thing, and that conversation is just gone. How do we fix that?
More reason, and that goes back to my Johnny Appleseed kind of analogy here. All the more reason why, the more apple trees that are out there, the less they're going to be able. It's kind of like, okay, I'm gonna get a little biblical here. It's kind of like when John the Baptist was preaching against the Pharisees and the Sadducees, and it's like, what are you gonna do? Everybody around him loves him. You got to be careful there. You can't just say or treat him any old way you want to. And so I'm basically, I hope that if we plant enough apple trees, that they're not going to be able as effective at their,
We wanted to ask too, and if you can't answer this in a certain way, that's fine. What do you think about the more extreme side of things, like people like Claudia, who are very against MAT and are pushing a very different narrative that some people feel is kind of leaning in the wrong direction?
We each have our battlefield. And
Yep.
the reason why Claudia's battlefield is as it is, and I don't always agree with that, but the reason why it is as it is because so many people uh, who are not substance abuse patients are basically being put on substance abuse drugs.
Mm-hmm.
And so she's trying to, she has she'd rather nobody be on that medicine than the appropriate people be on that medicine. And I think to a certain degree, the way I deal with the people who are technically on my side but not completely on my side is I take what I can. I find the areas that we agree on the most, and then the areas where we're in not disagreement, I don't crap on their platform. I just don't amen it.
Right.
And Claudia knows that I've come out, and there were a couple of times, like early on, that I came out directly against some of her stuff because, she said that, when people would steal things out of medicine cabinets, that it was a good thing because it created a safe street supply. And I said that was not my responsibility as a provider to create a safe street supply. It's, and still feel that way. You see what I'm saying? So
Yep.
but then I let it go. I made my statement and I let it go because I think Claudia is better than I think Claudia is more good than bad. And I'll be on her. I'm sure I'm going to be on her podcast
Podcast.
sometime soon too. And I think she's absolutely she's a force. And maybe sometimes that force doesn't always go 100% in the direction that we want to. But do we want her to be quiet? I don't think we want that. You see what I'm saying?
And that's one of the things we were trying to have her on here back in the day, and I don't know if like emails just got mixed up or what, but the whole reason we wanted her on was to kind of give her our side and show her the reason why her way of doing
Because there are things that she does that hurts your cause.
right.
Legitimate, right?
I feel like it hurts everybody's cause. You know what I
Right.
mean? 'Cause she does a lot of very good things, and I agree with a lot of things she does. It's just she could frame it differently, but I feel like she doesn't know how.
Right. And here's what I think. I think that all of us are waiting for our first real win. Can we say? Can we be straight up with each other and say that right now none of us are actually in a place where we're winning. We're
Yeah.
all in a place where we are surviving. We're definitely the world is a better place because of our efforts, but nobody is actually good. And so I think that it's going to take somebody in one of our in one of our realms to actually score a win that we can all look back and go, well, that's undeniable, a win, for us to kind of build on that and to help reform the narrative. Claudia and you two are not the only two divides in those realms.
No.
We could all come together easier. I guess the easiest way to come together would be if Claudia and you two could come together, and that would be like wonderful. Hey Claudia, you heard that. Anyway, but the divide isn't just at this level. There's a lot of misunderstanding all across the MAT versus the pain community.
I feel like I was one of those people that started off as a pain patient and kind of got thrown to the wolves, thrown to my own vices. And
quite frankly, Craig could say the same thing.
That kind of rocked me. But I feel like if the right doctor would have heard me and I could have worked together, I don't think I would have ever went down the roads that I went down.
I agree that a lot of people who ended up in overt substance use disorder, if they'd had the right provider, could have at least kept them in. Remember, I have three categories: therapeutic use, substance use disorder, and I'm not going to hold up the other one by itself, but is chemical coping. I just realized what I was about to do, and I wasn't going to do that on camera. But chemical coping. At worst, you could have at least been maintained in chemical coping and not progressed all the way to substance use disorder.
Right.
And I agree that. But again, that's where I feel like whether the DEA ever does the right thing or not, the battlefield is still in each and every room.
What would you see as a win? I'm just in general. What would you describe as a win?
Bring the two sides together?
Yeah.
Okay. Because I was just sitting there thinking about that. I mean, honestly, I think, honestly, you're right. It's probably provider driven. But there has to be, you know what? Unfortunately, there has to be money in it. Because the reason why the two sides are at each other's throats is because there's money in it. There are people profiting off this argument.
Greed.
There are people profiting off of this argument. And, so it is provided, because there was one doctor, was his name Tyler or something like that, that he tried to have conversations about the fact that, pain management and MAT both deserve to have their needs met. And man, he got drowned out. I haven't seen any of his videos in
Dr.
a long
Nichols.
time.
Yeah, Dr.
Nichols. Yeah, Terry.
Yeah.
Terry, huh?
Taylor Nichols.
Yeah. And I think he honestly had the right. I didn't. Again, I take the good when I see the good, and I don't. I just kind of overlook the bad. But he had most of the stuff I'd agree with, especially from the. I don't understand why these two communities are fighting.
Me either.
There needs to be maybe a somewhat more magnetic Dr. Nichols, and because I'm not saying he's not, but
That's the problem. A lot of things, if he did not agree, he was very abrasive, which I understand why, but that was the problem. Yeah.
His delivery needed work. I would agree with when I didn't agree with him. Most of the time, I didn't agree with him because it was delivery. He
Yep.
was a know-it-all, for lack of better terms, and I don't mean that. And I would say that I act that way sometimes myself. I'm not trying to throw dirt on him. I'm just saying that's how it
We
came
all
across.
do.
And when it,
We all do.
yeah, right. But I'm saying that when it really matters, if you come across that way, a lot of times your message gets lost in the delivery.
Yeah. And that was the thing. I mean, we had him on. He has a great message. He has his pharmacology knowledge is very intense, so he understands why a lot of things work the way they do. And I feel like it's one of those positions where he could really help. But that's the problem. It's delivery is everything, especially in a situation like this where everyone's at each other's throat all the time.
Let's face it, this is all about our fields too.
Yeah.
And I hate that we reached this point because I'm afraid I'm going to have to sign off here. But I do look forward to round 3 and picking up maybe even on this because it needs to happen. And I would love to be part of a unifying conversation. One of the things that makes me useful in this area is that I now do MAT, and so now I'm primary care, pain management, and MAT, and let me tell you what. Uh, the right person on Suboxone, I don't do methadone, but the right person on Suboxone, oh my goodness, the difference it makes in their life.
Right.
And the life you can hand just like a gift, you can literally bow tie it and hand it back to them. It is astounding. And you're right. There literally should be zero conflict between those two parties.
Awesome. Well, Dr. Mike, thank you for coming on. Thank you for writing an awesome book. I was really mad I left mine in the kitchen this entire time, and I meant to go grab it before I started the live. But yeah, your book was awesome. I encourage everyone to go read. Go to Amazon. Did you have any?
Search my last
The
name.
link
It's an
tree.
easy way to do it. You can also search Dr. Mike Says, but you got to work with it to get it to ignore the quick putting spaces in it. And you can go to my particular page and the TikTok shop.
Cool. Okay. Thank you for coming on. And if you want to do round 3, we're down.